Malaria is our topic of discussion today. Let's define malaria. Malaria is an acute febrile infectious disease caused by a parasite of genus Plasmodium and is normally transmitted from person to person by female mosquitoes of genus Anopheles. Why do we say by female mosquitoes? It's because male mosquitoes feed on plant nectar. Malaria is found more in tropical and subtropical regions of the world. Let's see the causes of malaria. There are 5 species of malaria parasites which affect human beings, namely Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, Plasmodium ovari, Plasmodium noris. And of these, Plasmodium falciparum is the most harmful malaria parasite in the world. Then the incubation period is within 7 to 10 days, but this can be prolonged in people who have taken antimalarials. Then in some species like Plasmodium vivax and Plasmodium ovari. Plasmodium noris rarely affects human beings. So let's see the life cycle of malaria, and within the life cycle, it's where we are going to talk about the pathophysiology. And the pathophysiology starts, or the malaria cycle starts, when an infected female Anopheles mosquito bites a human being. It injects in sporozoites. These sporozoites migrate to the liver and they attack the hepatocytes. When they attack the hepatocytes, so you follow on your screen. Stage 1, sporozoites are injected within the body. So 2, they migrate to the human liver. Here they affect the hepatocytes. When they are in the hepatocytes, they multiply asexually. When they multiply asexually, they form merozoites. Here, merozoites will move. So when the cell is full, it will burst. So when they burst or rupture, they go into the bloodstream. Others go into the lungs. Then some remain in a dormant form. So these which remain in the dormant form are the ones we call the hyponocytes. Then the merozoites, which have gone into the blood saturation, they attack the red blood cells. When they attack the red blood cells, some multiply sexually to form gametocytes. So when these immature gametocytes, that is the male and the female, are formed, now a mosquito will come again and consume the parasite. So that is the immature gametocytes. When these immature gametocytes are picked up by the mosquito, when they reach in the mosquito, these gametocytes will develop further into mature sex cells, which we call the gametes. When gametes develop into actively moving ocnites. Ocnites, it means a moving fertilized zygote. So these ocnites, they will burrow through the mosquito mid-gut to form oocytes on the interior surface. These oocytes will burst, releasing sporozoites, and these sporozoites will move to the body, and then they will move to the salivary glands of the mosquito. And the cycle begins again when a mosquito bites another person. So when you look at this cycle, it shows that we have two hosts. We have a primary host, which is the mosquito, then the secondary host, which is the human being. The pathophysiology is divided into two. The exoerythrotic phase, which starts from 1 to 2. Then from 3 to 4, we are in the erythroetic stage. So that is the pathophysiology. So from there we can talk about the signs and symptoms of malaria. Signs and symptoms of malaria, the first sign is fever. And this fever is the most characteristic symptom of malaria. The fever in malaria is intermittent, i.e. it comes and goes many times. So this fever is divided into 3 phases. We have the cold stage. It is when the patient feels cold and shivers. The hot stage. It is when the patient feels hot. Then the sweating stage. It is associated with sweating and relief of symptoms. That the first sign is fever. Second is loss of appetite. Third is weakness. Then lethargy. Lethargy is a pathological state of sleepiness or deep unresponsiveness and inactivity. Or we can say this is a state of which the baby or the patient is too weak. Then another sign is vomiting. We have diarrhea. Then we have mild dehydration. Dehydration is the abnormal loss of water from the body. Then I tried to generalize these signs and symptoms according to their system. The central nervous system, we have headache. Fever, we talked about it. The musculoskeletal, we have fatigue. Fatigue is feeling of tiredness. Then we have pain. We have back pain. Then skin, we have chills, sweating. Then in the respiratory tract system, we have dry cough. Why do we have cough? Remember we talked about the merocytes moving when the hepatocytes burst. Some go to the respiratory tract within the lungs. Then we have spleen enlargement, which is called splenomegaly. Then in the stomach we have nausea, which is the urge, feeling like to vomit. So in severe malaria, we have signs and symptoms there. For severe malaria, the other ones were for uncomplicated malaria. Then for severe malaria, first sign and symptom is change in behavior, like confusion and drowsiness. Drowsiness is feeling like sleeping. Then altered levels of consciousness, or the patient might be deep in coma. We have convulsions. Convulsions, this is the sudden irregular body movements caused by involuntary contraction of muscles. Then we have hypoglycemia, which means low blood glucose. Then we have acidosis. This is accumulation or buildup of acid within the bloodstream. There is difficulty in breathing, which is due to pulmonary edema. Pulmonary edema, which is also called wet lung. This is excessive accumulation of fluids within the lungs. Then we have acute renal failure. This is when there is failure of the kidney to filter wastes from the blood. Severe anemia, that is lack of blood. Shock. This is a life-threatening condition that occurs when the body is not getting enough blood flow. We have hemoglobinuria, which means presence of protein hemoglobin within urine. We have oliguria. This oliguria means little urine, and this can be related still to the acute renal failure, and the urine at this time is dark in color. Then we have jaundice, which is yellowing of the skin caused by the buildup of bilirubin in the blood in the body. Then we have bleeding tendencies, prostration, which is the act of lying stretched out on the ground, all extreme physical weakness and emotional exhaustion. Then we have hyperparastemia. This is the increased number of parasites within blood. Then hyperplexia, high temperatures which are above 106.7 degrees Fahrenheit or 41.1 degrees Celsius. Then there is severe vomiting. So those are the signs and symptoms of severe malaria. Then differential diagnoses. Most diseases which cause fevers can be differential diagnoses, like respiratory tract infections, urinary tract infections, meningitis, abscesses, then measles and other infections with rashes. But here we shall generalize it before the rash comes out. Then investigations. The first one is the rapid diagnostic test, the RDT. Second is the thin blood slide for diagnosis, the malaria smear. Then we have PCR, which means polymerase chain reaction. This is more in the developed countries. Here they will go in and get the DNA of the parasite. Then these tests, if required, we can do a random blood sugar, we can do HB levels, then a lumbar puncture to rule out like meningitis and others. Treatment for uncomplicated malaria. So this treatment, it includes all patients, including children of 4 months of age and pregnant women in the second and third trimester. First line treatment is artemether-lumefantrine. These doses vary, so dosage is according to age or weight, but I'm going to use body weight. So for body weight, from 5 kilograms to 14 kilograms, the patient will take 1 tab BD for 3 days. 15 kilograms to 24 kilograms, the patient will take 2 tabs BD. 25 kilograms to 34 kilograms, patient will take 3 tabs BD. Then above 34, patient takes 4 tablets BD. First line treatment. Then first line alternative, artesunate, amodiaquine. Second line medicine is dihydroartemisinin pipequine. So here the patient will take, also this is given also to weight, according to weight and age, but I will use according to weight. 5 kilograms to 9.9, the patient will take half a tablet on the first day, second and third day, meaning half a tablet per day for 3 days. Then 10 kilograms to 19.9 kilograms, the patient will take 1 tab OD. 20 kilograms to 39.9 kilograms, the patient will take 2 tablets OD. Then above 40 kilograms, the patient takes 3 tablets OD. Then in pregnant mothers within the first trimester, we give quinine tablets. If quinine tablets are not available, then it means we can give the first line treatment, which is artemether-lumefantrine, or we can give dihydroartemisinin piperquine. Then we go to treatment for severe malaria. For severe malaria, all age groups, all patient categories, first line treatment is artesunate, and artesunate is given 2.4 milligrams per kg body weight. And for children below 20 kilograms, we give 3 kilograms per kg body weight. And it is given 12 hourly. We give 3 doses until the patient is able to take oral medicine. Then first line alternative is IV quinine, where we give 10 milligrams per kg body weight. Or artemether injection, where we give the first loading dose 3.2 milligrams per kg body weight, or D. Then the other remaining doses we give 1.6 milligrams per kg body weight, or D. For 3 days, those will be 3 doses a total until the patient can take oral medication. Intermittent preventive treatment in pregnancy. So these pregnant mothers can be given IPT, which is sulfadoxine pyrimethamine, and it is given it is started at 13 weeks of gestation, and it is given monthly till delivery. Here it's good to do a direct observation therapy. The pregnant mother takes the drug when you are observing. So, general principles of managing. When we are managing these, we manage fluids very carefully. Adults with severe malaria are very vulnerable to fluid overload, while children are more likely to be dehydrated. So what do we do to manage that? We institute a fluid balance chart. Intravenous artesunate is the medicine of choice, so it is the first line treatment. At health facilities without admission, IV drug administration, at health units without admissions and IV drug admission facilities, give a pre-referral dose of rectal artesunate as soon as possible and refer for further management. Another one says, at a health unit with admission or IV drug administration facility, treat with IV artesunate, which is the first line drug. Then if IV route is not possible, use IM route. If artesunate is not available, use IM artemether. Where do we give it? Into the thigh, never in the buttock. Or if artesunate is not there, then we can give IV quinine. Antipyretic. An antipyretic can be given to reduce body temperature, like paracetamol, diclofenac. We have discussed about all these. These all have full lectures. Paracetamol has and diclofenac has. Then anticonvulsants may be given if the patient is convulsing, e.g. diazepam. Treat detectable cause of convulsions, e.g. hypoglycemia, with dextrose. If there is vomiting, the patient can be given an antiemetic, and this can be given half an hour or to 1 hour before taking the antimalarial drugs. Then nursing considerations: give supportive care and symptomatic treatment such as tepid sponging for fever, fanning, reducing of the bed linen. So in nursing care, most times we are aiming at on relieving the signs and symptoms without use of medication. So you can tepid sponge to reduce fevers. Observations: TPR, BP, temperature 4 hourly, and record all the observations. In medicine, what is not recorded is not done. You have to record. Give health educations regarding personal protection, prevention of malaria, and compliance with treatment. The patient should rest for 1 to 2 hours after taking the medication due to the risk of dizziness, vomiting, and hypotension. Those are the side effects of the anti-malarials. The patient should be given psychological support by encouraging the patient and giving comfort. Encourage a nourishing diet with plenty of oral fluids. If the patient is unable to eat or drink, pass a nasogastric tube. Monitor fluid intake and output. There you institute a fluid balance chart. We talked about it. Ensure proper hygiene of the patient as a whole and the environment. Then we talk about the complications. Complications, they are mostly the signs and symptoms of severe malaria. Impaired consciousness, we talked about it. Severe anemia, that is lack of blood. Renal failure, pulmonary edema, acute respiratory distress syndrome. We talked about all these. Shock, we defined it. Acidosis, hemoglobinuria, hemoglobin in urine, jaundice, yellowing of the skin, then repeated generalized convulsions. We talked about all these complications and we explained them. So lastly, we can talk about the prevention. How do we prevent malaria? The first one is give effective treatment and prophylaxis. Eliminate parasites from human population by early treatment and effective treatment. We have talked about the antimalarials we give for effective treatment. Then protect vulnerable groups with chemotherapy following drugs that are used like chloroquine, which we can give mostly in sickle cell patients, and these sickle cell patients can be also IPT. Then doxycycline, we have mefloquine, which is given mostly in the non-immune visitors, the tourists. Then pregnant mothers to be given IPT. Then cotrimoxazole it is taken mostly daily by HIV patients, and we don't give IPT to people who are taking cotrimoxazole daily. Then to reduce human contact with mosquitoes. First is use of an insect treated net. Second, destroy adult mosquitoes by spraying of dwellings with insecticides or use of knockdown sprays. Then wear clothes which cover the arms, legs, and use repellent mosquito coils. Another one is control of bleeding sites. How do we control them? Eliminating collection areas of stagnant water like old tires, empty cans, containers, potholes, and others. Then destroy mosquito larvae by dosing stagnant water bodies with insecticides or with biological methods like larva eating fish. Then lastly is giving public health educations on the above measures. Thank you for listening. I remain Basilika Ashraf Jung, the presenter.